intervention can we, what type of intervention can we provide? Because again, here my observation and that of other people is that when it comes to mental health conditions, quite often we think mostly in a biomedical term. We think mostly in terms of medication which need to be given to people. And there is a little of psychosocial intervention which are provided to people suffering from this condition. And yet we know now more and more, quite a number of these psychosocial intervention, they are actually quite appropriate and can help into facilitating healing and reintegration in the community. So that's one of the challenge, the biomedical orientation. Not to say that I'm against medication, not at all. I am very supportive for the use of medication, but that use of medication has to be appropriate and evidence-based, as they say it, and not be used blanketly for everyone. My previous speaker, I think, I'm sorry, as I said, I came late, has mentioned something related to addictions. So here again, with people who are in pain because of violence, poverty, and displacement, they would have things like poor sleep. They will be feeling unhappy with life. They will be anxious with what is happening. So it's very easy for us to find them also being given some of this medication which can be addictive to them. Some medication like the benzodiazepine given for either anxiety or sleep, which should be given for a very period of time, would be then misused for a long time by people if they are not supervised. And that could be a door to other type of addiction. So the biomedical orientation is quite a big issue. And unfortunately, quite often when we start talking of mental health, generally that's how we frame it. It's framed as mainly as a biological condition, which actually sometimes we use that orientation to try and destigmatize the condition, but then we take away psychosocial issues, as I've mentioned, that of violence, poverty, and displacement, and we do not look at those psychosocial issues. Then the other challenge, as well, as I said, this is a silent suffering, is that when it comes to mental health, we generally think in terms of hospital and maybe clinic. We don't have an orientation, a community orientation, where people are actually treated right in their family, where they belong, where they live. And generally, it's also proven that when the treatment is provided in a family context, there is a very high chance of how will I call it, of improvement, of healing. I want to use the word curing. Actually, some years back, I don't know now, it was acknowledged that people suffering with chronic condition like schizophrenia, they had a higher chance of improvement in countries like Africa and India because they were mainly treated in families, in community, unlike in the first world countries where they were treated in institutions as hospitals. So the hospital-centered approach is definitely another challenge we have. Again, I'm not against hospital. We definitely need hospital because some of these conditions might need specialists where people have to be admitted and have decent investigation and treatment. But quite a number of people would need to be taken care of in their community, if not their community, but in any other community, to allow them reintegration as part of treatment and recovery. So the other thing I would like to say when it comes to mental health, this I believe it's actually the main issue for us in Africa. It's related to what I would call resilience. As I said, we are going through a lot of turmoil related to violence, related to poverty and displacement of people. Unfortunately, we do not have program in place to help people, first of all, prevent these violence and poverties and prevent a mental illness. We do not have that in place. Quite so much of our intervention is generally when someone is sick, when damage has been caused, then we come in. And even then, again, as I said, it's a limited intervention, which is biological oriented and does not actually help the person to be rehabilitated. So we do not facilitate the process of recovery. If I may say that. So I feel at the two extreme, then before the condition is in place, we could come with program in terms of how do we build healthy community in Africa. That is actually the question. How do we build healthy community in Africa, regardless of where someone finds him or herself? Like as I started here to say, we do have people from other countries who get sick here. There is still a way if we sit together, of course, with the South African or South African community and community from outside to say, as organization, how do we support each other so that the person who is afflicted by this condition does not feel alienated, does not feel isolated, and does not feel excluded. I feel there is a way of working to help the person either go back home, of course, in a safe environment, or stay in wherever he is in a way that he is allowed to be reintegrated. So that I think would be a way of working to develop our own resilience as African. How do we develop a resilient community so that we prevent this condition? And when the condition has happened, then for us now is to think in terms of what could be the rehabilitation program which could facilitate the recovery of our fellow African. Maybe the last thing I would like to say here is again, unfortunately, we do not realize the connection between mental illnesses and physical conditions. I strongly believe many of these chronic conditions we have today, be it what would say hypertension, some type of diabetes, and even HIV and tuberculosis, in a way, they are intertwined with mental illnesses. Either these physical conditions start and they would develop, they would also lead to some kind of mental health conditions, or the mental health condition would predispose someone to develop this condition. So it is important for us as well to also, when we discuss issues of mental illnesses, to be having an integration, a way of looking at it, so that we actually look at health in a broader sense. So I think this is what I would share so far, and thank you for having me, and I'm really excited that we have this initiative. Again, I'm sorry I came late, but I'm sure we'll be able to find our way in agreeing on how we can help have some intervention in Africa. Thank you.
Thank you so much, Dr. Alphonse. That was really a detailed information. Thank you. And I just wanted to just say to everyone on this platform that we asked all the speakers to we did not request them to talk about a particular area of interest I wanted to, and we told them whatever you think is the urgent need in your country or in the continent, let's talk about it. And it's interesting to hear that, I mean, from the first two speakers about connecting our ecosystem and mental health issues, the ecological factors leading to mental health issues, use of drugs, I mean, integrating these issues and looking for integrated solutions to address them, and also ensuring a healthy community. I mean, it's interesting to know that these issues cut across and they are on the front burner for like urgent solution is required. And I wouldn't want to speak much. I'm just moderating or facilitating. I would want all the speakers to actually finish up what they have to say before we entertain questions. Having said that, I will want to invite Mr. Victor to also share in 15 minutes what his experiences are and what the needs are and what are the likely strengths we have on ground to address those needs. Mr. Victor, you have the floor. Over to you.
Thank you so much, Loretta. So my name is Ayao Victor. I am Director for Center for Youth Integrated Development, and I'm also the Director for Platform for Cooperation on Mixed Migration. So before I make my contribution, I would like to just address something that Dr. Alphonse said. So in relating to migrants, we don't use the word illegal migrant because it's a word that the West are using to criminalize migrants. So the right word is either you say irregular migrant or undocumented migrant. So that campaign has been on for a long time, not to use that word illegal migrant because no human is actually illegal. So Dr. Alphonse, thank you for your contribution. We're actually doing the same type of work. Now, for us here, the situation is, so we work with return migrants, and then we work with migrants in Nigeria, both documented and undocumented, and then we work with people on the move. And like, you know, people in the mixed migratory flow, I mean, they face a lot of situations. And one major problem is the mental health issues. So for instance, those people that are deported from abroad, some of them are unlawfully deported. For instance, the EU return policy, they have a policy on who should be returned and who not to be returned. Or in most cases, you realize that they even return people that ought not to be returned. They separate families. There was a time I was talking to somebody, his wife and children are back there in Germany, and he has been deported to Nigeria. And the daughter kept asking, "Daddy, when are you coming back?" And he cannot actually give, you know, a definite date because he actually cannot go back again. So these are the people that we meet on daily basis, migrants in Nigeria, especially the undocumented one from our neighboring country, whose rights are being violated by their employers. But because of their status, they cannot seek for justice, you know, and they live with those pains. And how long can they actually live with those pains? Like I said the other day, this prompts us to, you know, seek for help for them by going to Germany to, you know, have some trainings on mental health. I mean, trauma healing precisely. Because there is this misconception here when they talk about mental health, people generally believe that you are saying that they are mad. and then nobody wants to even come closer to you. And so it takes time to begin to explain to people, what you mean by mental health. You're actually not saying that somebody is mad or whatever, not that you have a mental condition and stuff like that. Thankfully, it's gaining ground gradually in Nigeria at the moment. People are embracing it, but I mean, it's very, very small. I mean, from my own understanding, the acceptance of wanting to seek help is still very, very low, except those people who are in that mixed migration flow, because these ones are already a client that you are working with, so they will generally open up to you. So in terms of people embracing to go for counseling, to seek help, I mean, it's like I said, it's gaining ground. But if you have been listening to the news, you realize that Nigeria, I mean, now we're having high rates of suicide. That's something that is usually not like this before. So like I said, gradually we are entering into the system. And so due to these challenges, we're actually looking for different ways at which we can help people. Because another thing is that even when people want to seek for help, there are not enough professionals that can actually help them. So we somehow use guardian and counseling for mental health issue, which from my understanding, it is not the same thing. Mental health is mental health. Guardian and counseling is something else. And so in our own little way, we've been trying to, as I talk to you, we have an online training going on now with a coach in Croatia. We set up a barefoot therapy class. A barefoot therapy is the first responder to people with mental health issues. So we have that training, ongoing at the moment. I had to excuse myself not to join today, so that we can have as many people in the community that can actually respond to people that are having mental health issue. We have another group that will be having meeting tomorrow. I mean, that it was even through that channel that I met Mr. Moshood. So the challenges here at the moment is that there are not enough hands, to help people that are in need. And one good thing is that, so we have people who are interested to work with these people if they can be trained. And like I said, that's why we set up that barefoot therapy class. It's free. It's a 6-month course. They meet every Thursday online. And then twice in a week, they come to my office for physical meetings. So we call other people who are into the mental health space to come and have class with them. And then one other thing that we do that we have not started to do is that we want to take them on a field work, either to go into the migrant community or to go to the IDP camp or the refugee camp, so they can practice what they have been learning. But the fact is that because they are not well equipped, we all agree that they can't go out at this moment because they actually don't know what to do yet, because this class started 1st of February, and this is the second batch. We had the first batch 2 years ago, and because of some, technicalities, we couldn't have the next one until now that we have started. So again, the challenges is that there are not many people on ground to assist these people. Interestingly, we have many people that want to be trained. Even at the moment, we are also talking to an organization in Australia. They offer some kind of training called, I think they call it mental health first aid. We just started discussing with them. So we want to see as many people that we can train, so that, I mean, there may not be enough, but at least it's better than what we have now. The prof talks about a drug issue. I mean, they're everywhere. We have a program that we want to do for years. We have not been able to do it because, I mean, we need a lot of people on board. It's about taking the street children out of the streets in Lagos, but because we don't have enough hand, that will do that, we couldn't go into it, because we know that, I mean, we're going to be needing maybe 1 person to 3 people, and considering the numbers that you are going to have, we don't have that number yet, so we couldn't go into that program. So for me, the strength that I would say is that we have willing people that want to learn. I consider it a strength because you can have resources to train people and there are no people to be trained. So for us, we see it as a strength that, okay, there are people that want to be trained to do this particular, to work with this category of people. That's one of the inspiration to set up this platform for cooperation on mixed migration. You know, people are willing to work with people, you know, on the road. So what are the needs? Yes, like I've already mentioned about the needs. The need is, I mean, more of training. And also one other problem that we used to have here, let me say we now because it's a collective team, online meeting doesn't really work too well for us here, you know, because of you know, data issues. Some people complain they don't have data and stuff like that. And even where they are having the network is not steady and all of those stuff. You know, so we're looking at there's this program they do in the UK in the business cycle, where during summer people volunteer from UK to come to, I mean, some countries, there's this organization Afford that did that some time ago. So during summer, people volunteer to go to certain country to go do business training for people. I mean, so if this is available under this umbrella, I mean, it would be good for somebody to volunteer to come to Nigeria, you know, have a session, have a training 1 week or, I mean, whatever time they have, because I, for one, I also like physical training more than online training. You know, I like it, even though to a reasonable extent, I have a steady internet, but I always prefer that physical training. So if this is something that, you know, we can work out under this umbrella, I mean, it will be perfect. So that's all I have to say. Thank you for having me.
Absolutely, Victor. That was really clear to say that. I mean, we know the world is getting smaller in terms of, I mean, virtual meetings and all that, but nothing beats the in-person one-on-one relationship, and that makes community even more enjoyable. Yes, we've taken note of that, and I also hear you about the struggles with returning migrants. I also hear about the struggles with reaching out to children on the streets. One of our resource persons here, Latifa, works with young people, children, both in the United States here in New Jersey and in Nigeria. So that's one of the breakout groups we're thinking about. And we will actually dissect all of these issues. And I'm sure you're going to be hearing people, you're going to be having people asking you a lot of questions in that regard. So you can guide our discussion tomorrow. So thank you very much, Victor. Very well. I will quickly call on Dr. Julia from Zimbabwe to share her experience and her presentation as well. Dr. Julia, over to you. Dr. Julia, if you're there, could you just come on, introduce yourself and
thank you.
Go ahead.
Thank you very much. I'd like to share my screen. I hope it will come out perfectly.
Absolutely.
Can you see my screen?
Yes, and you can also share your video as well. I mean, it's whatever makes you comfortable. Yes, exactly. Because I see a lot of people are actually, we're not seeing people's faces.
Let me look for the icon. There it is. Yes, I hope you can.
Thank you. It's good to see people's faces.
Yeah, it is. It is. So my name is Julia Mtambara. I'm a clinical psychologist with a PhD in clinical psychology. I'm a senior lecturer at Midland State University in Zimbabwe. I'm going to talk about research in Zimbabwe, challenges that we face, what we are doing currently as researchers. Firstly, I want to talk about the program that I've been running for for 3 years, the DAS program. The full name is Drug and Substance Abuse in Primary Schools. This research was funded by AAP through its Community Access to Child Health, or ICACH grant. And the objectives are to empower grade 6 learners to impart knowledge on drug and substance misuse to grade 6 learners. So I've been working with grade 6 learners, training their teachers, their class teachers, to offer mental health literacy in the area of drug and substance use, because there's been an increase in drug and substance use in Zimbabwe, especially after the COVID-19 pandemic. So with this program, it's mainly a literacy program where we are providing information to learners as well as their parents, so that they can start conversations on and around drug and substance misuse. And as a background, there's been an increase, and there's been drug and substance use has reached crisis levels in Zimbabwe. Actually, there is an interministerial task force that was set up by the government to look into drug and substance use issues. And we have seen that there have been some consequences of drug and substance use, like school dropouts, failure, low productivity, high crime rates. And for the last program, when I joined the meeting, there was a presenter who was also talking about drug and substance use, and I think it's a huge problem in Africa, and our nations are just waking up to the challenge, and we are trying to see how we can deal with drug and substance use using local solutions that are locally invented. So the DAS program is a universal program targeting all students in grade 6. It's focused on primary prevention, where we are saying we want to delay initiation. We want to educate the youngsters so that we delay initiation, because we have found that the effects of drug and substance use are more severe when children start using substances when they are very, very young. At least if it's postponed to later years, the effects are less than when people start abusing at a very young age. So we want to delay initiation, and we have come up with resources: the students' booklet, the facilitator's guide, and the parents' booklet. And for the students' booklet, there are 6 lessons that learners go through, and there are tasks that they do at each and every chapter of the booklet. And we also have a resource for parents. We have parents covering 4 topics on drug and substance use. And we have the parents in WhatsApp groups. We are using WhatsApp groups to communicate with parents. Also, we have a teacher's resource. So far in this program, as I said, we're in the 3rd year of running, and we have trained about 2,000 learners, 675 in the first year, 620 in the second year, and 605 in the 3rd year. Altogether, we have 2,000 parents. These are parents of participating learners who have received education in the WhatsApp groups, and 50 teachers have so far undergone training in drug and substance use, so that they can also pass the information to their learners. And we have, so far we have 2 publications from the work that we've done. And speaking about research in general, the most pressing needs for researchers in my country, international collaborations, networking. We have heard another speaker talking about drug and substance use challenges in his country, but we are sort of working in with the same things. but separately. So we may need to have more collaboration and learn from each other. Also, mentoring of young researchers. In Zimbabwe, we have had the challenge of brain drain, where seasoned researchers have left the country, and now we have young researchers who have just come into the space and they need more mentoring. And also research skills like conducting meta-analysis, systematic reviews, scooping reviews, big data science, data analysis, advanced data analysis skills. Those are some of the research skills that our researchers may need so that they can carry out community research. Use of technology in mental health interventions. We also need mentoring on how we can use technology in mental health interventions, and also learning from other countries or other researchers who have been using technology in mental health interventions. The challenge is, as I said, brain drain. We have many of our researchers who are leaving the country. Also, funding is an issue because sometimes you want to do large-scale research and you need some funds to be able to carry out that research. And absence of prioritization by government, you find that there isn't much funding from government to universities in terms of funding for research. And also because of that, some of the solutions that we come up with, or that government come up with, are not informed by research, because usually research is supposed to be used as the solution or to inform solutions. But because there is that disharmony between government and researchers, we find that sometimes we don't have informed decision making. And amongst the researchers, because of economic challenges, there's been very little motivation. Say you want to do research, mainly it's for use during promotion, but there isn't much incentive in doing research. The access, the strengths that we have new universities that are coming up in Zimbabwe, and old ones are growing. And for universities, the mantra is publish or perish. So it's coming out, doing research is actually beneficial to those who are at university. Also, we have some universities that offer local grants, local research grants, although these are small grants, at least it's something. And also we have in our universities, our universities have been mandated to come up with innovation hubs, like at Midland State University, where I am, there's an innovation hub where if you have an idea, it can be nurtured and it can be grown. So those are assets that we have. Unfortunately, for the social sciences, participation in the hubs has been a bit slow or low. And in terms of priorities for research, we would really love to be trained in implementation science type of research, where our research will then have to make impact in the communities that we live. It's sort of, as you can see on point 3 there, lack of collaboration between researchers and implementers. We have many NGOs, non-governmental organizations that are implementing various programs in the country, but they don't make use of researchers, or they don't make use of the research space to publish their findings. There's a disconnection there, where we are saying we need to be involved as researchers. Also, drafting of policy documents, policy briefs, so that our research can have impact. So most of our research is in journals, some journals that are not open access, and we don't have our population is not benefiting from some of the research that we are doing. Mainly we are doing research for promotion, and it's logged in journals that and they need a lot of money. for people to access. I was just looking at one of the articles that we did and published in an open access journal. They are charging 35 pounds to access the article. But for us researchers, we are not getting anything from those access fees. And I think it's really unfair for researchers. So in terms of research areas, drug and substance use and abuse is a priority in our country. Older adults, we have many people who are retiring. We have a population that is aging, and it's imperative that we research in that area. Also, common mental disorders, anxiety, depression, just having people understand, having knowledge about these disorders. Also, suicide is on the rise, and it's an area that may need further exploration. Come to the end of my presentation. Thank you very much.
Wow, Dr. Julia, that was I was shifting around on my chair to say
Over
there's
to
so much.
you.
Yeah, can you hear me? Hello? Can everyone hear me?
Yes.
Okay, thank you. Dr. Julia, can you hear me? Okay. Okay,
Loretta?
yes, you can hear me, Dr. Julia.
Yes. Did you hear my presentation?
Absolutely. I was just trying to
Okay.
respond.
Okay, I thought I was just speaking to myself.
No,
Thank
no,
you.
we all had. I was just saying while you were presenting, I was shifting around on my chair to say, wow, that's a lot of assets we have back at home. That's a huge resource we have, and I can also we can also see what those challenges are as well, and the strengths are also obvious. And in terms of the research issue, Society for Community Research and Action, that's what we are about. And I'm very certain we have senior experts on this platform um, who will begin to look into those issues and provide solutions and strategies and guidance. And I hear about the children issue as well, the grade 6. It's interesting that we're going very quickly with those children to see how we can use the prevention approach, to ensure that we don't have more cases and incidents of drug use and overdose crisis in Zimbabwe and across Africa. So thank you very much for that very wonderful presentation. Finally, to present before I open up for discussion, I don't know if Dr. Barbara is here. I don't know if Dr. Barbara is here.
Unfortunately, Dr. Barbara is, yeah.
Okay.
I don't.
Okay, Fungi, if you can hear me, okay, we hear you. Before I open the floor for questions, I would also want to remind our experts, our senior colleagues here that tomorrow you're all going to, everyone that has been identified to speak, tomorrow you're going to be responding to this different areas from your own perspective, an area of expertise across what has been discussed today. And so so today is just for us to hear what the issues are in Africa, to hear what the strengths are, to also hear what the assets are in Africa. And tomorrow we are going to come in with all of our strategies, all of our expertise, even to profile or to work together as partners and collaborate and see what next, to address some of these issues. So thank you everyone for staying, and thank you for listening. And I'll open the floor right now for questions. For I think in the next probably 15 minutes, we'd like to take questions and responses. Dr. Pamela, I see you. Thank you for coming. Dr. Pamela is the Zimbabwe president of the Zimbabwe Psychology Association. We see everyone on the platform. Thank you everyone for coming. So questions for our respective speakers. The floor is open. Can anyone hear me?
Yes, we can hear you.
Yes,
Okay.
we can hear you.
Okay, thank you. So questions across board for all the speakers. I mean, it doesn't have to be for the speakers. We can just throw questions around and anyone can pick pick up the questions and respond. Yes, please go ahead, Dr. Alfonso.
Yeah, look, I just wanted to say, yes, we from the different speakers, including myself, we have been talking more of mental health as a challenge. But I believe it's very, very important for us to also kind of think out of the box. Maybe that will come tomorrow, but we can start thinking about it as well, because I don't have a solution, but this is how I look at it. I strongly believe that what we need are issues, as I said, with the challenge, violence, poverty, and displacement. These have caused a fragmentation of the community and even of our culture, and it doesn't allow community development. So I feel what we need is some of the intervention at the community level to facilitate community development, to facilitate community peace, and to facilitate community health, because it doesn't help to be healthy in a sick society. It's very, very important. So I just wanted to raise that these three issues are issues we can also start looking at, because when we say mental health, people just want to think, okay, you need to be a psychologist or a doctor, but we need people from any other sector, be it a teacher or an economist, social researchers, and so on, for us to find avenue to facilitate community development, community health, and community peace. Thank you.
Thank you, Dr. Alfonso. Okay. Before I begin, is there someone else that have a question? Before I begin to call our senior experts, colleagues on the platform, allow me to invite Dr. Amber Kelly. She's Executive Director of the Society for Community Research and Action. And she's happy to be here, I'm sure. And she'll just like to greet us. Over to you, Dr. Amber.
Hi, everyone. And thank you so much for the invitation. I am happy to be here. And I am going to just share a brief slide deck of some of the happenings that are going on with SCRA. Okay. Highlights of some of the things that have been taking place that we have going on that others can.
Amber, we can't hear you.
Can she hear us, I wonder? Can you all hear me?
I can hear you.
I can hear you, Dr. Erica. I can hear Dr. Amber.
Can you all hear me?
Yes.
Okay. Just rewind a little bit. Sorry that did not hear what I said. So today I'm going to talk about the state of SCRA affairs. I'm just sharing some highlights and some of the initiatives and programming that we currently have taking place. Is the outcome of the work of our strategic planning committee. And so one of the things that was very apparent as an organization is that we needed to have in writing who we are in terms of identity. This is a planning committee.
Hi,
The audio is going in and
yeah,
out.
Amber, yeah, I was just gonna say you are going in and out.
I'm wondering if it might also be helpful maybe to have the transcription or something turned on in case it kind of goes in and out. Maybe we could also read what you're saying.
The captions should be on. If you go to the bottom right-hand corner, you should be able to see them. You can click on the more button and hit the caption, so you should be able to see them.
Can
Got
you
it.
all hear me now? Okay, all right. So, and feel free to interrupt me if it happens again, and I'll see what else can take place. And so this identity statement was a collaborative effort between SCRA membership, spearheaded by the Strategic Planning Committee. And this went through multiple iterations, and members had multiple ways that they could provide feedback, and it was incorporated into this final statement that you see here. The Society for Community Research and Action, SCRA, is a multidisciplinary member-based nonprofit organization. Our society's Division 27 of the American Psychological Association, aimed at promoting social justice. SCRA serves members across diverse fields who share a commitment to community research and action, such as community psychologists, community researchers, and community practitioners. Using participatory processes, our society supports our members throughout their training and careers to partner with communities to advance liberation via anti-racist and anti-oppressive action and practice, education, theory, and research in multiple settings. And this identity statement was finalized November of last year. Really excited to share how we have had so many interest groups and councils that are engaged in work, not just within our society, but also outside of our society. And some groups have even been recharged. We also have, not on this slide, but we also have various committees that have been recharged as well. And so if there's ever an interest collectively among members for a particular topic, you're always welcome to start an interest group in that particular area. And you'll notice some interest groups over time may become inactive, but that is only perhaps maybe due to the topic. So maybe some topics, they fit the context of the time that we're in, and sometimes over time, it's like, hey, we don't need to address that anymore. And so always feel welcome and free to start any sort of interest group in a topic that others are engaging in similar work or have a similar interest. Recently, SCRA Executive Committee had their midwinter meeting. And so one of the outcomes of that meeting was sharing the following statement as it pertained to the Israel and Palestine conflict. The Society for Community Research and Action, Division 27 of the American Psychological Association, calls for an immediate humanitarian ceasefire, not a pause, together with the unconditional release of hostages, both in Israeli and Palestinian, and the delivery of relief at a level corresponding to the dramatic needs of the people in Gaza. And this statement went through our rapid response process. The following is a statement that was led by our school engagement group. This statement on the effects of law enforcement in school settings. The position statement is available open access through the AJCP, the American Journal of Community Psychology. Drum roll, please. Our next biennial will be held at Michigan State University in 2025. The dates are June 9th through the 14th. And over the next upcoming months, you'll see additional information about the upcoming event. Another conference that is taking place this year is the International Conference of Community Psychology, September 10th through the 13th at the University of Republic in Uruguay. And so if you have not made your arrangements to participate in that, really encourage our members to attend. So the biennial and the international conference are usually on off years of each other. So that allows for participation at both conferences on different years. So now it is election time, and so we have candidates running for our vacant positions. For the last few years, a new initiative that we have is giving an opportunity for members to engage with the candidates. Previously, response from members was like, hey, we don't know who's running. We just get this ballot and we just look at it and we don't know. And so trying to create a space that is a supportive space for members to come and connect with our potential candidates for our vacant positions. Our president, Lacey Brookins, hosts a monthly office hours. His upcoming office hours will focus on membership and leadership development. He recently sent out an email with a Padlet for people to engage and respond. And the goal of his office hours it creates a supportive space where members can come and share their ideas. You can learn more about his vision and also collaborate and strategize on how to shape leadership development within SCRA. The upcoming session is April 9th. Right. If you have any questions or curiosities, you are always welcome to reach out to me directly, and I look forward to meeting new members. Thank you very much. And I'm happy to address any questions, comments, or curiosities at this time.
Thank you, Dr. Amber, for greeting us. We have our brothers and sisters from Africa, from Zimbabwe, from Nigeria, from South Africa, from Ghana, and from Kenya on the platform. And I'm sure they're excited to also be part of what's happening in SCRA. And we'll keep brainstorming and keep using the resources we have back here to support identified needs and help to assess the strengths that we can leverage on to address those needs back in Africa. So we thank you very much for joining us, and we're excited that you're part of what the initiatives are for SCRA Africa. So thank you very much for being with us. Thank you. Thank you, Dr. Amber. I wanted to go back to the questions. I don't want to call names, but I know that my mentor is here, Dr. Erica. I also know that we have a very senior expert here as well, Dr. Palmer. And I also see Dr. Fasika as well. And I would just like you to put in one or two words. You have your whole day tomorrow. And I also know Dr. Moshood is here, but I'm not sure he can speak now, but I know he's listening. So anyone can just go. Dr. Palmer, Dr. Mingo, please, the floor
Sure.
is, yes.
I first of all, I'm very grateful for the convening of this meeting. I think that it is just a gigantic step in the right direction. And I was hesitant to say the name. I want to echo Dr. Ayawu Victor. I don't want to be so informal, but I want to echo those sentiments about structural concerns, and not in along with the focus on mental health as well, particularly given that this is kind of that lens that I think we all share, that kind of structural lens. And it seems inescapable to think about structural causes of some of the concerns and issues that we brought up here together, without, of course, thinking about decolonialism and thinking about, anti-Blackness and anti-racism. And those things are, to me, crucial in understanding. And it might seem like an odd thing to discuss in the most populous Black nation in the world. I did not, or for Nigeria there, or for the continent that's predominantly Black people, of course. But given the impacts of colonialism that are lasting, everlasting in the communities that we're all working in, I hope that tomorrow there's time to discuss colonialism and anti-colonialism and the ways in which Pan-Africanism might be a lens through which we can start to address some of those systemic issues as African people home and abroad and amongst the diaspora. That's my big hope, I would say, is a Pan-African approach and lens through which we might be able to start to address some of the issues certainly caused by colonialism and the reverberating impacts of such.
Absolutely. Yeah. Thank you, Dr. Mingo. Dr. Palmer?
Yes, hi, thank you. You know, I was listening and jotting down notes. And so what comes up for me, of course, is I think this is an awesome space or at least beneficial space in terms of this, of the, I think what the issues on the table that revolve around mental health. And as a professor who teaches students earning their PsyDs in clinical psychology, it certainly is resonating with me in terms of if you're looking at interventions or treatment approaches or whatever that might look like. Certainly, I am looking forward to tomorrow in thinking through this because as a community psychologist, we're going to come to the table with a different lens. And that includes treatment approaches or interventions coming from an ecological level of analysis versus deficit-based. And we're going to be looking at what is it I want to bring up? Healing-centered engagement versus individual approaches, et cetera. So I think all of that is going to raise all of our awareness or bring us to the place where to address issues around migrants and around anything that has to do with addictions, mental health, et cetera. I think the approach has to be collaborative. The approach has to be Dr. Mingo brought up something brought up the issue of everything that has to do with racism and anti-Blackness and so forth. And so I'm looking forward to thinking about this more tonight and of course tomorrow. How do we collaborate in both these spaces that at one point clinical psychology and community psychology probably could be looked at as anti-theses or what do you want to call it, opposite each other, so to speak. So to that end, yeah, I'm looking forward to ways that will certainly be.
Sorry. And that's accountability. I admitted myself into treatment.
I'm sorry, yeah, I wasn't able to finish, but yeah, so just basically coming together tomorrow to think through the lens of both clinical, community psychology, social work, mental health, whatever that might look like, to find spaces that, one, remove the colonialism, removes the white gaze, removes the possessive investment in whiteness, particularly if we're looking in American spaces. And so, yeah, again, thank you. I think this is worth it. I can see a long-term future of collaboration and how we come together to address issues that are impeding community members and in the spaces and communities that we work in. So thank you all much. I look forward to tomorrow.
Thank you, Dr. Palmer. Thank you so much. Dr. Kapalamula, you want to say a word?
Yeah, I was just putting in the chat that it was really nice just hearing everyone's perspectives. I'm really looking forward to the conversation tomorrow. I actually had to run. So I'm really looking forward to more conversations and, just hearing everyone's insights. And I think that there are a lot of people who bring different expertise in here. And I think that there's some good work that we can do together. So
thank you so much. We all look forward to tomorrow. We look forward to tomorrow. Thank you so much. Dr. Fasika Alam? You're muted, Dr.
No.
Fasika.
Yes, can you hear me?
Yes.
Okay. So I really don't have much more to add. Just happy to be here and listen in to everyone doing this amazing work. Of course, from our perspective, we come from a practitioner perspective. Looking to highlight really the needs and the challenges faced by African and other Black immigrants and refugees in our state here in Illinois, and really exploring opportunities for participatory research. And so I look forward to this continued conversation.
Absolutely. Thank you so much. And just to get a word from Dr. Moshood, if you can speak, if you cannot, just give me a thumbs up or give me a sign that you cannot speak, and I'll let you be. Okay, Fungi, please go ahead. Yes, Fungi, you can unmute yourself. Yes.
Okay. 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 Can you hear me?
Yes.
Am I audible?
Yes, you
Hello?
are. Yes, you
Okay.
are. We can hear you.
All right. Okay. Thank you. Right. I also wanted to add on that I've realized there's an observation that is practitioners, psychologists, and interdisciplinary approach that we are going to take. Particularly focusing on Africa, we want to look at issues to do with poverty, unemployment, violence against women, how we can make intervention strategies which are homegrown, using our indigenous knowledge system. I think if we can have conversation around that, creating our
Fungi, we lost you there. If you can hear me, you want to try and connect again? Okay. Okay, so I guess what fungi is trying, fungi is the Southern African.
knowledge system, not just parroting from the Eurocentric side, but coming out with our Afrocentric.
Afrocentric approaches. We hear you. Absolutely, we heard you. And I would echo what he said. I'm sure a lot of us, heard him. We're trying to see that the strategies we'll be looking at tomorrow is very indigenous. And back to what Dr. Migo said about decolonization, we want our strategies to be decolonized and to be as indigenous as possible. Relating it with what is doable and possible and obtainable and sustainable back at home in Africa. So having said that, if Dr. Moshood is unable to join us now or say a word, I wouldn't want to keep us for longer because we have another 90 minutes to discuss and dissect and come up with strategies for next steps tomorrow. So I want to thank everyone for joining us today. And we look forward to continue these conversations tomorrow at same time, 10 a.m. CST. And in Nigeria, that's 4 p.m. In Zimbabwe, in Southern Africa, that will be, I think, 6 p.m. And East Africa will be 5 p.m. thereabout. So thank you everyone for coming. We really appreciate it.
Thank you, Loretta, for your leadership and your guidance on this path. I'm so honored and grateful to have your leadership today.
Thank you, Dr. Migo. I really appreciate those kind words. Thank you. Please, if there's
you,
something.
Loretta, also.
Thank you,
Thank
Prof.
you very much. It's been
Thank you,
awesome.
Prof. Thank you, Prof. Thank you,
Thank
Prof.
you, and bye, everyone.
Thank
Thank
you.
you.
Yeah,
Thank
take
you,
good
Dr.
care.
Pamela. We'll get to
Yes.
hear from you
Thank
tomorrow,
you.
Dr. Pamela. Thank you so much,
Absolutely.
everyone.
Take good care. Okay.
Thank you,
See
Dr.
you
Palmer.
tomorrow. Yes.
Thank you.
Bye-bye.
Bye. Thank you, everyone. Thank you.
Thank you. Bye-bye.
Thank you, Dr. Alfonso. Thank you so much.
And I'm going to go ahead and stop the recording for you all.
Absolutely. Thank you.
No problem.
Thank you so
No
much.
problem.
Thank you, Dr. Amba. Thank you. We'll talk to you tomorrow.
Okay, when I leave, because I have host, everyone will be
That's absolutely okay. Yes.
okay. I just didn't want to, end and like.
No, that's okay. We're good.
Okay, take
All
care.
right. Bye.
Bye.
Thank you.